look at the prevalence, how common these problems are, and for that we're going to focus particularly on the most prevalent issue that you will come across, which is bladder leakage or urinary incontinence. And then we're going to have a look at the different types of electrical stimulation that can be used across the whole spectrum of pelvic health, and focus in more specifically around the devices that you have for pelvic health in the neuromuscular electrical stimulation. So we'll define what those are, and we'll have a look at the different types. And then finally, we're going to have a look at how we can use eSTIM to treat the symptoms of pelvic floor muscle dysfunction, in particular looking at some of the parameters electrically and the programs that we might choose to use with these patients. So first off, let's think about what happens when the pelvic floor is not working properly. And the two key areas that can be affected for men and women are bladder and bowel. And in terms of bladder symptoms, we might see that they have to go to the toilet more often, more frequently. And that might include at night time too, which we specifically define as nocturia, which I will define more further on. Commonly, patients will complain of urgency, and sometimes urinary leakage as well. Bowel-wise, they may have issues with constipation, fecal urgency, and fecal leakage or fecal incontinence. In the female population, we might see issues with genitourinary prolapse. That's a very common problem. It actually affects up to 50% of women across the world. But not all of those women affected with prolapse will have symptomatic prolapse. So that's a lot lower number that actually have problems that they are aware of because they have a prolapse in their vagina. Both men and women who have pelvic floor dysfunction will complain of decreased sexual function, and those pelvic floor muscles have a significant role to play in both male and female sexual function. And then where we perhaps don't think of issues is if the pelvic floor is not working properly. The pelvic floor forms the base of the cylinder of the abdomen, and so we can often see associated hip or pelvic girdle, lumbar spine dysfunction and pain that's related to pelvic floor dysfunction. It may be chicken or egg, as the English phrase goes. The hip or the back might be a problem already, and that causes the dysfunction in the pelvic floor. But reversely, the pelvic floor not working properly can cause symptoms elsewhere with referred pain. So we're going to focus in a little bit more on the bladder symptoms, and particularly thinking about female bladder leakage, but this will apply across to male problems as well, if any of you have clients or populations that are treating male populations. So these definitions are taken from the International Continence Society standardization documents, and the reference for the bladder incontinence definitions come from a paper by Halen et al. In 2010. If you ever want to look for a good resource in this field, then the ICS standards documents are excellent, and they're freely available from the ICS website. You don't have to be a member of the organisation to access them, but they define all aspects of pelvic floor, bladder and bowel dysfunction and prolapse. So that's quite a useful place to go. When we talk to women who have the problem of incontinence, they actually don't identify themselves with it being incontinent. If you say to them, who is the person who's incontinent, they'll think of a little old lady, perhaps living in a care home or a residential home, who is actually leaking urine quite severely and maybe has an odour about her and having to wear large incontinence pads. Younger women and menopausal women even tend to think of themselves as not having incontinence because that's a disease of the elderly, and they'll talk instead about bladder leakage. So when we're talking to consumers, that's often the language that we would choose to use, whereas clinically it's defined as urinary incontinence. When you have bladder leakage, it might be a very occasional leak, but it's having a huge impact on you because you don't know when it's going to happen. Or it could be happening every day or frequently every day, depending on the severity and the type of condition of leakage that you have. And the impact on your quality of life is not always directly related to the severity. You could have this occasional leak, but because you're so afraid of it happening, you stop a lot of activity. Many women have an avoidance behaviour habit when they have urinary incontinence, particularly stress incontinence, and they'll just gradually draw back from activities like tennis or Zumba classes or going to the gym. because they leak, and so they can control the leakage by actually not doing the things that make them leak, but that's actually withdrawing them from society. And we'll look further on at the burden of the disease of urinary incontinence, and you'll see there's quite a lot more factors that can be affected. Some of the definitions around the incontinence symptoms will focus on the bladder, but actually the primary cause for the majority of women is actually not that they have pathology in their bladder, but it's that their pelvic floor muscles are dysfunctioning, and often that they're weak. So we need to focus in on teaching women about their pelvic floor and how to get that stronger to actually overcome the leakage that they're having from their bladder. As far as prevalence of urinary incontinence across men and women, if we actually converted the statistics into population studies, you could actually say that urinary incontinence, if it were a country, it would be the third largest country in the world behind India and China. That's massive. That's a huge amount of people that are actually having this problem of urinary incontinence, the majority of which are probably not talking to anybody else about it. Looking at the male-female split, we can see that over 300 women globally, about 12.4% from this Irwin et al. Paper in 2011, were actually having a problem. And down as low as people 20 plus that were the cohort into this sample across all ages from 20 upwards, you can see that it's actually as many as 423 million people, men and women across the world, a huge amount. What are the risk factors? Well, the top two there are age and obesity, and that's not necessarily that they're the most prevalent, but actually across a lifespan, they're the most relevant. And we do see prevalent symptoms increasing with age, as can be seen by the graphs on the right-hand side. And as we know, obesity is a huge health issue across the world, and actually getting older and getting larger are the two huge risk factors for more severe urinary incontinence happening. In the female population, we tend to focus a lot on pregnancy and mode of delivery, thinking about forceps deliveries or the ventouse suction cap deliveries, instrumental deliveries. But actually, as people get older and we look at the prevalence in men as well, it's not always all about pregnancy. And we will come across women who have weak pelvic floor muscles, who've never been pregnant, who've never given birth. We see a rise in irritable bladder symptoms, so overactivity and urgency and frequency following surgeries to the abdomen, and in particular hysterectomy. And also some of these women will have a hormonal change at the same time, so they get the menopausal symptoms effect and the fact that they've had abdominal surgery. It does vary across ethnicity and race. Your mobility can make a difference. You might have urgency incontinence, but if you can get to the loo quickly, you might make it. So you're actually not incontinent, you just have the urgency. Whereas if you're quite immobile, it's very difficult for you to get there. And of course, sometimes when people have had hip replacements or hip fractures, as part of their rehab, they're given a toilet raise, which actually makes it more difficult to go to the toilet. So they're having to sit perched up high on a toilet seat, and that's even more time to get to the toilet, and kind of aggravate leakage. Other health comorbidities like diabetes may impact. They might have a peripheral nerve neuropathy, and the pudendal nerve that provides the pelvic floor innervation is particularly susceptible to peripheral nerve issues in diabetes that's uncontrolled. Dementia can have an impact. Hormone replacement therapy may be actually trying to combat the symptoms of menopause, but it may not actually be sufficient to affect the tissues around the vagina and the bladder and the urethra, all of which are estrogen dependent. So when estrogen levels drop, you can be taking HRT as a tablet or a patch, but you may still need some topical estrogen therapy in the vagina. Urine infections can be a trigger to incontinence in a lot of people, and they should be excluded before we go ahead with any treatments. We'll see that in the contraindications list to using STIM, and there may be lots of other comorbidities that are actually adding to the problem. As much as incontinence is prevalent, it has a huge impact on quality of life. And if you look at some of these common disease processes and look at the quality of life scores, you can see that urinary incontinence features higher than stroke and higher than Alzheimer's disease as impacting on quality of life. And it's up there with things like heart disease and diabetes and severe back problems. So it's a huge impact of quality of life. And this is quite an old slide, but I do use it quite a lot just to summarise really the impact of the burden of the disease of having urinary incontinence. It's a collection of symptoms rather than a disease process itself. But all of these factors going round the clock. So if we start in the middle at the top, physical changes, so limitations or cessations of physical activity. So as I said, avoidance behaviour, not going to your Keep Fit class because you might be frightened of leaking, not going to the gym. Psychological factors, guilt. A lot of women that I see through my clinical practice will say, oh, it's my fault that I've got this problem. I should have done my exercises when I had my baby. I didn't bother doing them, or I didn't know how to do them, and I didn't seek any help at the time. And they actually feel guilty that they've caused the problem themselves. Leaking as well can lead to depression. There's a huge crossover between depression and urinary incontinence. They might lose their self-esteem, be frightened of being a burden on people as they get older. Frightened of this lack of bladder control. It's instilled in us as children when we're potty trained that it's socially acceptable to be continent. So to find yourself as an adult being incontinent and out of control, that is a huge impact on your psychological status. And there's the fear of smell as well. And as we withdraw from activities and these fears, this psychological impact, that can actually have a huge impact on social interaction, affect relationships. You're not getting intimate with somebody if you're frightened of leaking when you're having that intimate moment. And actually travel becomes a nightmare. And particularly with COVID, that's had a huge impact for a lot of the patients that suffer with urinary incontinence. They're safe places to go to the toilet, popping into a McDonald's restaurant or a coffee shop or using a pub or a hotel. They've all closed at the moment, particularly in a full lockdown that we have in the UK. That's a massive impact. And in fact, we've even seen a new phrase on social media called the adventure wee, that you're actually finding a tree or a bush and going out in the wild and having a wee. If you need to go, if you've got urgency and frequency, not having access to toilets is a huge issue for you. Domestic changes, so you might have to have specialised underwear or bedding if you're sharing a bed with somebody else, but you have a problem with nocturia. That might even lead to bedwetting as an adult. That's a huge problem, and they might actually having to wear special clothing. The famous phrase by women with incontinence is, I have to wear black because it hides the leakage. So they have a big handbag and black trousers. That's the badge of honour for incontinence, sadly, for a lot of these women. It might impact on their ability to work. If you have a job where you can't leave your place of work, so you might be a receptionist or you might be a cashier at a checkout, you suddenly can't get up and rush to the loo because your bladder's telling you it needs to go urgently if you're in that kind of environment. And I have had patients again who've said that they've lost jobs because of their lack of bladder control. And if you are using the toilet frequently, then lots more loo breaks than your average employee, so decreased productivity. And back to this impact on social relationships, it may have an impact on your sexual function and your ability to be intimate with somebody else, so having a huge sexual impact. So a massive burden of disease from a little bit of bladder leakage, as sometimes people will brush it off as, oh, it's just a bit of a bladder leak, or when I'm laughing, they laugh it off. It's not, it's a lot more serious than that. So let's focus in on the female urinary incontinence and think of the different types. There are a lot listed in this Halen document, but I'm going to focus on the three main types, which are stress incontinence, urgency incontinence, and mixed urinary incontinence. So stress incontinence across the ages is the most prevalent type, accounting across all women for about 50% of the types of bladder leakage that women experience. But it is certainly more prevalent in the younger population, and you see those percentages change as you look at particular bands of older people. And so the urgency urinary incontinence will be more prevalent in the elderly population than in the younger population. Stress incontinence is a leak, an involuntary leak with effort, exertion, or on sneezing or coughing. So it might be a great big sneeze or a big cough or a series of coughing, or it might be running or doing your keep fit. The pressure goes up in the abdomen, that squeezes on the bladder, and if the pelvic floor is weak and the supporting structures are weak, then the urine will be pushed out of the bladder, and that's a stress leakage. Slightly different to that then is urgency urinary incontinence, where you actually get a strong urge to go to the toilet that you then can't control. So you might have frequency, you might be woken up at night time, which is nocturia, because you've got this strong urge to go. But actually urgency urinary incontinence is that the urge overwhelms you and you're not able to control it and you leak with that urge. And one manifestation of that has a separate description, which is called key in the door syndrome. But that can affect quite a lot of us if we've been at work or we've been out shopping and we're on the way home and we actually get to the front door and then suddenly get overwhelmed with a really strong urge to go and can't find the keys quickly enough. If your pelvic floor's weak, then you might leak on the doorstep. And that's what we would classically call key in the door. Now, over the years, urgency urinary incontinence and that collection of symptoms of frequency, urgency, nocturia have actually been classified by, actually developed by the pharma companies as overactive bladder syndrome. Quite a clever twist by the pharma companies who brought this terminology into common usage because it focuses attention on the bladder, and actually a lot of the medications that they will be selling actually work on the bladder. They don't work on the pelvic floor. But as I said before, quite often for women certainly, and to an extent for men, the problem arises from the pelvic floor, not from a pathology in the bladder. However, this has come into clinical language. It is a description that will be used by medics and clinicians alike, so we need to understand it. So if we see somebody described as having OAB dry, that means that they don't leak, but they have those irritative bladder symptoms of having to go frequently, having to go quickly, and actually being woken up at night by their bladder. Whereas OAB wet, they will have all of the above symptoms, but actually also have the urgency incontinence where they can't reach the toilet in time when they get that urge. The final main type then is mixed urinary incontinence, and this is much more common in menopausal women, and actually that's the age group that often seek professional help. So it's when we run any studies, if you look at the average demographics of the populations, it's often that menopausal age woman, sort of 45 to 55 age group. And these women will actually experience both urgency on occasions with urgency incontinence and stress incontinence when they're actually sneezing or coughing or exercising. And part of that may well be nocturia, and the true definition of nocturia is actually being woken up by your bladder during the main sleep period. So that's not if your back sore or the dog's barking outside to be let in the middle of the night, or the car alarm goes off. That will wake you up, and as human beings we tend to go to the toilet to get comfortable to go back to sleep. That's not nocturia. But if you wake up from sleep desperate to go for a wee, that is nocturia. Now, the problem we have is women don't read the Halen paper, so they don't necessarily know all of these definitions. So it's important that in any communications we have with them, particularly if we have preset programs on a stimulation machine, for example, that they actually know which category they fall into, because they don't tend to think of those definitions. And as I say, they tend to talk about bladder leakage rather than incontinence. So in summary, bladder leakage in women is a very common problem, and that's reinforced by a lot of TV advertising for pads, but it shouldn't be seen as normal. And actually one of the big pad manufacturers has just launched a new advert in the UK, and it's created a lot of backlash on social media, saying they've got a magic bullet that it's a pad in her pants so she can go to the gym. But actually, if she's got such weak pelvic floor that she leaks in the gym, she shouldn't be lifting heavy weights in the gym. So pads are not the panacea to this at all. And when we've been potty trained to be socially continent as a child, actually putting a pad on it still means that the urine is leaking out of the body and is being worn against the body contained within the pad. So yes, we're socially acceptable, it's not showing on the outside, but you're still leaking, which is against that strong social norm that we're built into when we're potty trained. The real figures then for women is about 1 in 3 women will experience bladder leaks at some stage in their life. And as we suggested before, that could be up to 300 million globally. it increases with age, and actually we can see 2 out of 3 women over 40 describing experiencing symptoms of urinary incontinence. And there are a couple of papers that actually show it's as many as 1 in 2 as you get over 60. So it affects women of all ages, whether they've had children or not. And the peak prevalence of symptoms is going to be around that menopausal age group of 45 to 55. So let's have a look at the pelvic floor in relation to bladder control. So if we start at number 1, this is the detrusor muscle, which is the smooth muscle of the bladder, showing in the orangey colour that that's actually going to be very relaxed as the urine starts to gather and fills the increase in pressure, and while we're filling the bladder, the pelvic floor and the urethral sphincter that's innervated by the same nerve roots as the pelvic floor are actually keeping that urine safely contained within the bladder, exerting pressure on the urethra. As the bladder fills, we will get the first sensation to void. Now, in many occasions, we won't be aware of this. This will happen and we'll be busy. So if you've been listening to me, some of you might have had a sensation to void, and it will have just been in your subconscious. Your body will have dealt with it, your pelvic floor will have tightened a little bit more in order to make sure nothing leaks out, and your bladder is relaxed and it will just carry on filling. Then when it gets to its full point, we'll get the normal desire to void, and that should be around about a pint of liquid, or somewhere between 400 and 600 millilitres. Now, actually, a lot of us, when we get a break, so if you've had a lecture before this one and you've dived onto this one and you grabbed a loo break, you might have actually gone when you weren't full. So we have a functional capacity, and that's around about 350 mils. And that would be when we would choose to go to the loo when we have the opportunity, rather than waiting until we're actually full, because often in work life or some social settings, we can't go straight away when we're actually full. So we will preempt that. Once we actually get to being full, though, and there's a toilet available, when we're actually in a position to void, and we should as women be sat down on the toilet, we can let the pelvic floor muscles relax and the detrusor will contract. So it's an opposite reaction. If the detrusor is contracting, the pelvic floor must be relaxing. And when the pelvic floor is tightening, then the detrusor should be relaxing. So they work opposite each other as agonists. I said we should sit down to do this because if women stand to wee or half stand, which is what some of us do when we go to the toilet, we'll hover because we don't want to sit on the toilet seat, or we'll be on holiday somewhere where there's a hole in the ground toilet, and because we're not used to going that way, we don't get into a proper squat. If you go into a deep squat, so crouching down on your haunches, you can wee properly. But for a lot of women in Europe, we will hover over the hole in the ground, or we'll hover actually over a toilet seat because we're frightened of sitting on it. And then our pelvic floor and sphincter can't relax, and the detrusor is trying to force the urine out against a closed exit. And that will irritate the bladder more and more and more the more you do that. So it's not good practice to do that. So hopefully none of the audience are doing that. They'll actually be sitting down. Guys, you have it different. So you actually have the ability to relax your pelvic floor because of its orientation. So you are able to wee standing up and write your name in the snow in a snowy winter. So we are designed slightly differently. So let's think about different types of electrical stimulation, and what I'm actually going to focus on in this presentation is the neuromuscular electrical stimulation, which is activating a muscle contraction. So that's the devices that we're looking at in the group of products that you have within TensCare. Neuromuscular electrical stimulation can be applied vaginally, anally, or via external skin electrodes. So we can actually get the muscles to contract, and we're going to focus on that a little bit more as we go through. But we're also going to touch on neuromodulation, where we can actually use the electrical energy to moderate the electrical activity in the nerve supply to the viscera, to the bladder itself, or to the bowel. And then the other group of products that we might talk about is electromagnetic stimulation, where we're using electromagnets to induce an electrical current within the pelvic floor. That will still be aiming to activate a muscle contraction, but it's just a different way of delivering it. So we'll talk about that a little bit more as we go through. So neuromodulation can be delivered as well through as the electromagnetic way. It can be delivered away from the pelvis. So SANS or PTNS can be delivered with a electrical current going into the sacral nerve roots. So the needle is placed in the leg over an acupuncture point, and it's actually into the lower part of the front of the leg or the side of the leg, and then there's a reference lead on the heel which allows the electrical circuit to flow through that area, and actually that sends afferent nerve stimulation up to the sacral spine that can inhibit the bladder. Now, unfortunately, there is a lot of evidence for this, but it's not robust evidence. So in the UK, we have the NICE guidance documents that tell us what's evidence-based, what's cost-efficient, and actually PTNS is not recommended as a first-line treatment in that guidance. And that's just because we don't have those huge randomized controlled trials that NICE would want to see to make a recommendation on it. So it's not that it doesn't work, it's not that there's no evidence, but it's actually just not widely used. And there'll be only specific areas that are offering this as a routine treatment. And in fact, there has been a paper just published at the recent ICS conference last week that was looking at, with an elderly population, instead of using the needle, using a surface skin electrode to deliver percutaneous tibial nerve stimulation. And that was actually not shown to be effective in that particular study. So there are efforts going on to gather more evidence, but at the moment it's not that widely used. Now, another application that we can use, and some of the small handheld units that TensCare have in their range can be used this way, is to place skin electrodes over the sacral spine. So as if you were placing TENS electrodes for obstetric TENS, you can place them a little bit lower down over the sacral area and actually deliver a low frequency stimulation to help neuromodulate and control bladder urgency symptoms. Again, we have some evidence in the literature, but not huge randomized controlled trials. So again, this is not recommended in the NICE guidance, but it is used by clinicians in the UK and in other parts of Europe that I'm aware of as another option for these patients if other treatments. Usually it's used when treatments have failed. Sacral nerve stimulation is going up a step. This would actually be done by a urogynecologist or a urologist. It is a surgical approach. The electrode leads are actually implanted into the sacral nerve roots in the sacral spine. These are done temporarily for 2 weeks and taped onto the skin, going through into orifices into the sacral spine with an external stimulator. If that's successful, more than 50% reduction in the leakage episodes, then that will become a permanent implant, and those lead wires are embedded into the sacral spine, and the little pacemaker is actually positioned into the buttock and implanted, and then that can be set externally. So there is quite good evidence for this, both in bladder and bowel, but it's quite a costly procedure and would always be a secondary care approach to that. So if we focus back in on neuromuscular electrical stimulation, what are we actually trying to achieve with this? We're trying to put the electrical current as close as we can to the target muscle to get the electrical energy to flow across the neuromuscular junction. Now, the neuromuscular junction is where the nerve axon actually attaches onto the motor unit itself within the muscles. And each muscle, the pelvic floor being the same, will have a number of different motor units with different types of activity. And each of those will have a neuromuscular junction. Now, in any muscle, all of those will be affected by the energy from a stimulation pulse arriving at the neuromuscular junction. So one pulse will actually deliver enough energy to make that motor unit contract. So we call it depolarizing when a motor unit contracts. And that's referred to as a twitch contraction. So not functional, not particularly therapeutic. It's just one pulse arriving, making that motor unit react. Now, if we can time a second pulse to come along per second, quickly enough that that motor unit doesn't have time to relax and repolarize and reset itself ready to contract again, it will stay contracted in a summate or fused contraction. So 2 pulses per second will make all the muscles in the pelvic floor actually go into a fused contraction. But then when nothing else comes after that, they will go back into their relaxed state. So you'll get a couple of twitches, but you won't actually feel a sustained contraction. Therapeutically, if we're trying to strengthen the pelvic floor, what we need to do is pick a frequency that delivers sufficient pulses to make the target motor units, whether they're a slow acting muscle or a fast acting muscle unit, to stay contracted. So frequencies that we'll use in the pelvic floor will be usually in the region of between 2 and 50, and the higher the number, the more motor units that we will get to stay contracted, the more it will feel like a contraction that we would do voluntarily. And I'll talk about that a little bit more as we talk about frequency. Safety first though. So before we think about how we're going to apply this, let's think about who we can use it with and who we shouldn't use it with. So when we should not use vaginal or anal electrical stimulation is if there's any tissue damage. So looking at the top box there, tissue damage, a vaginal infection or recent hemorrhage or hematoma. So certainly post childbirth, if there's actually still unhealed tissue post surgery, any infections that are going on, that must be settled before you can start using a vaginal or an anal probe. We would never use electrical stimulation knowingly in a known pregnancy. So we must screen patients if they're planning to have a baby or if we know that they're pregnant. If they're using stimulation and they become pregnant accidentally, they must stop using their vaginal or anal stim. We don't have any evidence to suggest that it's harmful to the fetus. In fact, there have been occasions where we know that accidentally women have used it in early pregnancy and thankfully the fetus has been okay, but we would not knowingly want to expose the fetus to any additional electrotherapy energy in that area because we don't know the results of that. Now there's a condition called atrophic vaginitis, which is a lack of estrogen in the vagina that can make the vaginal tissues extremely dry and irritable and prone to splitting. This is often referred to now as genital symptom of the menopause, so GSM, as a cluster of symptoms around the menopause, but within that atrophic vaginitis is one. So if you have severe dry inflamed tissues, then you would not want to be using a vaginal electrode. It might be that if it's not that severe, that you could proceed to stimulate a female pelvic floor using an anal probe, so that's worth considering, but generally it would be a contraindication to vaginal stimulation. Down to the bottom box, urinary tract infections. If it's active, then make sure that that's treated. You don't want symptoms of a urinary tract infection with irritation and pain and discomfort, and then having a stimulation in that area as well. That would be very uncomfortable. With regards to pelvic cancer, it does vary from country to country. Generally, the rule of thumb would be that if it's actually been a pelvic cancer and it's had treatment, it's had surgery, or it's had chemotherapy or radiotherapy, once all treatments have been completed and the surgeon is considering that patient is over their cancer, they don't have cancerous cells anymore, then it's okay to offer them stimulation. However, some patients are very risk averse when they faced any kind of cancer. And so if it's a pelvic cancer, like a prostate cancer or a uterine cancer, some patients will not want to have stimulation afterwards, even if they're symptomatic and it might help them. They would choose a different treatment. So it's a discussion to have on a case-by-case basis. But generally, if it's active cancer and it's having treatment currently, then you shouldn't be using vaginal or anal stim with them. And likewise, if a woman has had an abnormal smear test, she needs to have had a clear smear since her abnormal one. So if she's had any treatment or she's just been monitored and had another smear test, as long as that's clear, then it's okay to proceed with vaginal or anal stim. To the final box on the left, then, we wouldn't want to do any stimulation in the body, really, in any part of the body, if there's an implanted cardiac pacemaker. We know that therapeutically, when you stimulate the vagina or the anus with stimulation, it does awaken cells in the brain that actually are the control centers for the pelvic floor. So we know that we're having a transmission up through the spinal cord. That energy can be transferred around the body, and we do not have any safety data to say that it's safe to be used with a cardiac pacemaker. So my advice would be that in clinical practice, certainly, we would not want to recommend that. It should be avoided. And the other one then is there's likely to be changes to the tissues if there's been pelvic surgery of any sort within 12 weeks, that again, that might be affected by artificially making the muscles move in that healing period. So if there's been any neuropathy that's actually trying to heal itself, you could delay or stop healing if you give stimulation too soon. So that 12 weeks is a good safety thing for both post-childbirth and post-pelvic surgery. Times to be cautious then: if there's reduced vaginal sensation, then we can still proceed because they can feel it, but with a reduced sensation. So we proceed with caution. We might want to monitor them with supervision with a therapist in clinic. But this would be a sort of patient perhaps with MS where they've lost sensation around the vagina. They have some, but it's reduced. And this has been shown to be successful. One of my colleagues, Doreen McClurg, has actually published a paper a few years ago showing the use of stimulation in an MS population with great success. Now, obviously, if they have a severe vaginal or anal prolapse, that would be blocking the orifice, so you wouldn't be able to get a vaginal or an anal probe in, and you wouldn't want to make the pelvic floor muscles contract with a severe prolapse because it would be down below the level of the muscle. The bulge of the prolapse would be actually sitting below where you're going to make the muscle contract, so that would actually be potentially harmful to the prolapse. The question of epilepsy crops up, and you really need to have a discussion with the individual. If they're a stable epileptic, there is a risk that using stimulation in the body could trigger an epileptic fit. So we don't have evidence to say it's completely safe, and that risk does exist. So if somebody's able to drive and go to work with their epilepsy because they're stable, we wouldn't want to risk them having a fit. And any bleeding disorders, it's not so much that the stim will do anything to the bleeding disorder, but actually using a probe in the vagina or the anus, they may cause some tissue damage placing the probe, and then they could bleed if they're not well controlled. So they just need to be medically well controlled before they go ahead. Some dermatological conditions will be severely aggravated. So if you've got a really bad case of lichen sclerosis where the tissue on the outside of the labia and around the perineum is really, really inflamed and irritated, the last thing you want is to have stimulation. So check the skin, make sure that it's intact and that they're okay to go ahead. If there's any cases of sexual abuse, in some parts of Europe, it is suggested that that is a contraindication to STIM. Certainly in the UK, we wouldn't take it as a contraindication. We would proceed with caution. We'd counsel the woman that they may get stimulation in that area that brings back recall. So they need to be prepared for that. But cautiously, we would go ahead, and it can benefit that group of patients. So it's not a contraindication. I've put metal in the pelvis in this box so I don't forget to mention it. We can go ahead with it, and it's actually not really that we have to be cautious about it with neuromuscular electrical stimulation delivered vaginally or anally. However, there is a caution with some types of devices. So there's one particular product called Innovo, which actually is an external stimulation. It's like a pair of shorts, and you stimulate through 8 channels externally trying to get into the pelvic floor. Now, with that kind of stimulation and with electromagnetic stimulation, the metal would actually potentially divert the current because it's a much better conductor of electrical energy, so it could have an effect on where the current's going because it's a larger area that's being targeted. That doesn't appear to be the issue with neuromuscular stimulation. So things like a copper coil or a marina coil, a hip replacement, anything metal around that area is okay to use, and I've certainly used that clinically with my patients. I'm going to come on shortly to show you some different types of electrodes, and why we might consider different electrodes is if somebody has a nickel allergy. The less expensive electrodes tend to have stainless steel electrode plates on them, and they contain nickel. So if you're severely nickel allergic, you wouldn't want to be placing that in your vagina and stimulating yourself with it there for half an hour. So you'd need a different type of electrode. So when we're applying electrical stimulation to the pelvic floor, our aim is to get the electrical energy into the muscles. So in my opinion, by far the best way to do that is to place an electrode in the vagina or in the anus, because you're as close as you can get to the pelvic floor. If it's a bladder problem in a female, then you would probably want to be more anterior, so vaginal probe if you can. But if you place an electrode in the anus, it will travel into the pelvic floor and you will feel contraction anteriorly as well as posteriorly. So for men with pelvic floor disorders, you can do this quite successfully with an anal probe to treat the anterior pelvic floor. So we have a power source, that will be your device. You have your leads that lead to the electrode. This is an example of like the Liberty probe that you can see bottom left. That would be positioned in the vagina. There are probes that you'll see coming up on the next slide that actually have rings around them, and then there are probes with longitudinal electrodes. And I do prefer the longitudinal electrodes because you've got a better chance of getting at that shelf of pelvic floor muscle and having your positive and negative effect to the stimulation. So we're trying to get a good contact, and contact's going to be important. We'll talk about that as we go through. The pulse that comes, each pulse will be a biphasic pulse, so it has a positive energy and a negative energy, and that dissipates any heating effect, which is why we don't have a problem with metal in the field when we're going through the pelvic floor in this way. So one of the problems that we come across is that we're not actually plugging the patient into the electrode. If I want to charge my laptop, I will plug the plug into the main socket, and there'll be metal pins on the plug and metal in the socket, and they make a really good fit and a really good contact. We don't have that in the human body. So we're actually placing the electrodes next to the vaginal skin, which is a mucous membrane, which hopefully is quite moist. But actually adding a lubricant will make that a better contact. So if we have a poor contact, we'll get higher resistance, and the tissues will actually give us an impedance. So where we have that change of material from the electrode that's all wired into the machinery and the patient's tissues, that's a point of tissue impedance. And so moisture there will really help. That can change how those muscles react to the stimulation coming in. Can vary depending if the muscles are more tired. So if you've been busy all day and then you do your stim in the evening, it might not make as good a contact. If you're still having a hormonal cycle as a woman, then at different points in your cycle, the pH in the vagina changes, the tissue in the vagina mucous membrane changes, and the secretions are different, and that will affect how the stimulation can be transferred across. So you may actually need a different amount of energy. The intensity of it might have to be higher at some times of the month than at others to get the same reaction. And then the other big important thing is the fit of the electrodes. So you'll see when we look at the electrodes, they come in different diameters. So making sure that the electrode is the best fit, the best size for that particular individual is really important, and that will have a huge impact on the impedance. So we can help with the impedance by using a water-based lubricating gel. So KY jelly is a well-known one, but TensCare have their own that people can buy with their devices. So the TensCare Go gel would have that effect as a water-based gel. So here's our little shop window of what TensCare sell with regard to electrodes. So if we start on the top row at the left, you can see the Liberty probe, and then next to that is the Liberty loop, and you'll see the Liberty and the Liberty loop have actually got longitudinal electrodes, and that is my favorite electrode because it's going to have better contact along that shelf of pelvic floor muscle, with your positive and your negative energy being against the pelvic floor muscles. Below the Liberty on the bottom left is an anal probe, but we see the same design on the top right, but it happens to be gold plated with those circular rings. Now, depending on where they're positioned in the pelvic floor, either in the anal canal or in the vaginal orifice, there is a risk with those that if they're pushed too high up and up near the cervix, that top ring is actually not in contact with the pelvic floor. It will probably still work to stimulate because it will transfer the electrical current through the mucous membrane. It will get in there, but it's not as optimum an effect as the longitudinal plates. So size-wise, the Liberty and the Liberty Plus are 28 millimeters and 32 millimeters, and the Liberty Loop is 34. Now, the Liberty Loop is a design that's being used quite widely across Europe. It's the best-selling design of electrode across Europe, and is a good fit for the majority of women. So that would be my go-to electrode. It's quite lightweight as well. So if you do want to have somebody standing up and being active, which would be what I would do as a therapist, it's quite light to move around. It's about 20 grams, I think. Whereas the Liberty and the Liberty Plus is a slightly heavier electrode, but it's smaller, so it may just fit better and stay in well. If you have a very tiny vaginal orifice, then the Liberty Mini in the middle at the bottom is only 25 millimeters in diameter, and that can be used as an anal probe or as a vaginal probe. So it gives you quite a narrow diameter to be used with a small vaginal orifice. Now, the two electrodes on the right hand side are gold plated. That's not because we want to be very trendy and blingy about our electrodes, it's because it doesn't have nickel in it. So they're more expensive. If you don't have a nickel allergy, you don't really gain anything by going for the gold plate, but you will actually avoid a nickel allergy if you need to. So that's why they're there. So we're going to finish off by looking at how we deliver the stimulation. So we're going to look at these parameters on the left hand side, and you'll see the top four are in a bracket, because if you have a preset program on your device, they will usually be fixed in that program. So it might be a program for stress or urge or mixed or for toning, and those will be fixed. But I want you to just try and understand a little bit about why we're talking about frequencies and pulse durations and what that is. Treatment time can be set, and we'll talk a little bit about that. And then intensity is one of the most important things that we need to consider, because that's going to always be set by the user when she's using her stimulation. So frequency is how many electrical pulses being delivered to the motor units per second, and we measure it in hertz, Hz. And for the pelvic floor, it will respond between 2 hertz and 50 hertz. You could put a higher frequency in there, because once you get beyond a particular frequency, then muscles that respond at lower frequencies will be getting sufficient to make them respond and stay contracted. But there's no need to load the delicate pelvic area, particularly of men and women, with higher energy than we actually need. So the pelvic floor doesn't need any more than 50 hertz to get all the muscle fibers reacting and staying in a summate contraction. We can be more selective about which muscles we want to work. If we want to target the slow twitch fibers that give us endurance in the pelvic floor, the marathon runners that keep going all day long, then we would choose a lower frequency between 2 and 10 hertz. And if we want to choose the fast twitch power fibers, then we would choose a higher frequency between 20 and 50 hertz. But remember, safety wise, if we are delivering stimulation, we're potentially making a muscle work harder than it can do itself. So there is a risk with the high frequencies that you're getting absolutely everything. So even all your very fastest fibers that work on glycogen that burns off very rapidly are getting stimulated into a continuous contraction, however long that work phase is for. They will fatigue much more quickly. So generally, we don't want to be having high frequencies for a long time. And in clinical practice, I would choose a slightly lower level of 35 hertz to get the feel of a contraction, but without over fatiguing those very high frequency fast twitch fibers. The next parameter that is often preset on the machine but can be changed, and they are different across different machines, is the pulse duration. This is sometimes slightly incorrectly referred to as pulse width, because it's a measurement of time. So it's a duration, it's a measurement in microseconds. And it's basically the time that it takes for an individual pulse to start at no output, to reach what we've set on the machine as the maximum milliamp intensity, and to go back to its 0 output at the end of the pulse. So you can see the positive phase, the negative phase gets back to 0 again, and it's that length of time. The longer the time, so the higher the number of the pulse, the more impact it might have on sensory nerves. So the most commonly used pulse duration for muscle rehabilitation in the pelvic floor is about 250 microseconds, but sometimes people shorten that even lower to 125 sometimes, to actually avoid any stimulus or too much stimulus on the sensory nerves. And there's a payoff between shortening the pulse and getting sufficient intensity that the patient can tolerate to make the muscles actually contract. If we think of a slightly different application of stimulation, not to stimulate muscles, but to neuromodulate, we can still do that with a vaginal probe or an anal probe, but there we would be choosing a lower frequency and usually a higher pulse duration. And actually the Erickson and Foor work from the late 80s and 90s, which are the key references for this type of approach, actually use pulse durations between 350 and 500 microseconds. You'll also hear people talk about a duty cycle or a work-rest ratio, and this is how many seconds those pulses are going to be given for, as opposed to how many seconds they're actually resting. Again, because we're making that muscle work beyond what it can do itself voluntarily, we need to make sure that we give it sufficient rest time. So in clinical practice, it's common to give equal rest to work. So if you're working for 6 seconds of stimulation, you would have 6 seconds rest. But with very fatigable muscles, you might actually select a double rest phase. So you would have 3 seconds of work and 6 seconds of rest. And in fact, there are 1 or 2 clinical papers where they've used 5 times the amount of rest to work. But there comes a point where if you have too long a rest phase, you're actually not getting very much stimulation out of your treatment session of 20 minutes or 30 minutes. So we wouldn't usually in clinical practice go more than double. And that would be in a weak muscle, very fatigable muscle. And normal clinical practice, we would be giving equal. The other thing that we can look at is the ramping. That's the speed that it takes, or how long it takes over that work phase for the intensity to reach the maximum that you've set. So each pulse that's being delivered over each second is growing in intensity as it comes through, and the pulse, the rate at which that gets to its maximum is the ramping. Now, if you go from 0 to 60 milliamps in a split second, that's going to be quite a shock to your muscles. Clinically, I would use half a second, 0.5 of a second, but there are programs that are preset at 1 second or 2 seconds. Again, in some equipment, the ramp time is taken out of the work time. So if you shorten the ramp, then it's actually going to eat away at your treatment time. If you lengthen the ramp, if you have a 2 second ramp and a 3 second work phase, and the ramp is part of your work, then you're only actually getting 1 second of treatment each time. So you need to think about that. And actually, too slow a ramp is not physiologically what we do. So half a second feels physiologically quite right, although there's very little research to back this up. Most people who write papers on electrical stimulation used in this way don't actually give us this parameter and say what they set it at. So it's a good research project for somebody at some point in the future. Treatment time, again, hugely variable across various research papers. In clinical practice, it's certainly common to give between 20 and 30 minutes, and often to shorten that with a very fatigable muscle, a very weak muscle that's only beginning to learn how to work, might only tolerate 5 minutes at each treatment session. This can be given every day or every other day, and there are papers where it's being given 2 to 3 times a week, and one American study that gives it 5 days out of 7, so you get the weekend off. So it's a bit of an unknown as what's the optimum, and I think it's about how the patient feels. And actually, if they can do some pelvic floor contractions, stimulation might be an adjunct to them doing their exercises as well. Now, the key parameter that's really important is that this patient turns up the intensity sufficiently high enough to get that motor contraction to happen. And the problem we have in any stimulation, and particularly in the pelvic floor, is that the sensory nerves will sense the stimulation way ahead of the motor nerves. So with a few milliamps, you can be feeling stimulation on your sensory nerves, but you're actually not getting any muscle contraction. So it's important that they're trained to get through the sensory threshold and keep turning up until they feel the contraction. They should feel the electrode being drawn up and in if it's actually working. And if you can't get a therapeutic intensity up and you're there with the patient and you have a customizable program on your machine, you can reduce the pulse duration, take it down to maybe 125 microseconds to actually allow that intensity to be tolerated by the patient, because it'll have less effect on the sensory nerves. So I've probably slightly overrun time. We were a little bit late starting, but what happens when a woman's pelvic floor muscles are not working? Hopefully we've covered that, and we can see some of the issues she's having. We've focused in on urinary problems, and we've looked at how common they were. We've looked across at some of the different types of electrical stimulation in pelvic health, and then we've just finished off by looking at the parameters and what they mean and how we might use them with different symptoms of the pelvic floor. So I'm going to hand back to Lisa now and let her moderate any questions that you have. I could see a few coming in on chat as I was speaking, so we'll go back to doing that. Thanks, Lisa.
Hi, Julia. Thank you very much. Let me just bring everybody back into the room. Yeah, there were a few questions. I'll do it as soon as I can, as quickly as I can. Katri, I think, asked the question. Let me find her. Bring her into the room. Katri, can you hear us now?
Yes.
Yes, I think you had a few questions. Maybe if you just ask them now.
Yes. Let me turn in my camera.
Whilst I'm bringing everybody back.
Hi. Yeah, I had. Thank you. First of all, thank you, Julia, for the presentation.
You're welcome.
Sweet of you. I was wondering about UID, either hormonal or copper.
Yeah, so I touched on that. Even if it's a copper one, but with Mirena as well, so the hormonal ones, it's not a problem with the type of stimulation with the range of TensCare products with the neuromuscular electrical stimulation delivered vaginally or anally. That would be a problem if there was an electrical current going generally across the pelvis. So with the external shorts, that the Mirena or copper coil could actually divert the current up through to the uterus. So that would affect the ability for that to target the pelvic floor. It's probably not even then going to be harmful. It's not going to cause any heating because that has the same kind of pulse, but it's just not going to go in the direction that you want it to. Because we're below that and we're against, when we've got vaginal and anal stim, we're right next to the pelvic floor. The energy is going into the pelvic floor and coming back to the probe, and it's not going to be going up to the uterus. It's not going to get that high, so it's safe to use.
Okay, good. And what do you think about prolapse stages 1 and 2? Because they don't often get diagnosed or even mentioned by.
Yeah, they might not even be symptomatic, or if they are, they're mild. And strengthening the pelvic floor is going to help any symptoms of prolapse. There's a really good paper called the Poppy study. So you just have to be careful with the electrode. Vaginal prolapses are actually very soft, particularly when they're 1 and 2, they're inside the vagina. So as long as you push the probe in, so with the Liberty probes, they're solid, so that's going to push the prolapse out of the way. There have been comments made, and I don't actually agree with them, about the Liberty loop because it's hollow, and actually that's the same as the Periform, which is the electrode that I'm more familiar with. The Liberty loop is a newer version of that, but it's hollow, and so people have said in the past that, oh gosh, if you use that in the vagina and it's sitting this way round in the vagina, the prolapse is going to fall into it and get trapped. But it doesn't happen. It might come down, but actually when you put that probe in, you should put it in with the electrodes top and bottom. So it's going to push the prolapse on the front wall, or if it's the back wall, it's going to push it up out of the way. Then it will sit the right way in the vagina while you have your treatment. And then if you just gently rotate it, even if it has dropped down a little bit, it will just push it back up as you take it out.
Yeah, I have actually suggested women to put either a pillow or a blanket under the hips, so they are kind of reversed a little bit.
I would do that for pelvic floor exercises, but once you've pushed the probe in, you don't really need to do that.
Yeah, but prior using.
So if they're doing their exercises and they've got a prolapse that's beyond the introitus, then it's quite good to do that, to tip the prolapse back up. And it might be a good position to put their electrode in, because that's going to help to tip it in, so it's easier to put their electrode in. But once the electrode's in position, that's going to actually work like a pessary and hold the prolapse up.
Okay.
And Julia, I think some of our customers also was wondering, because obviously you said in your practice you're using electrostimulation whilst they are not laying down.
Yeah, so most of my patients, if they need electrical stimulation, will have their own unit and use it at home, because I can't see people, you need to either be doing it every day or every other day, in my opinion. So I don't see my patients that often, so they'll be taught how to use it at home. And once they've got over the initial getting used to setting it up, I will want them to stand up, to move around with their stimulator in, so that they actually can feel that activity of the pelvic floor being stimulated, and I get them to join in with it, because ultimately I want them to learn how to do their own contraction, because they're not going to have the stimulator there in the middle of the supermarket. If they sneeze, they need to know how to pull up their pelvic floor themselves. So using the stimulator to re-educate is really helpful.
So how would you?
Thank you.
You were. I don't know. I'm not muted. Yeah. You were just saying, would you then suggest this Liberty loop, which is lighter?
It is one of my favorite electrodes. I'm not so familiar with the Liberty loop itself, but I've looked at the dimensions of it, and it's the same as the one that I currently have in my practice, which is the Periform that Neen have sold for many, many years. So I don't think yours has been around as long as that, but it's the same product. So it's a lot lighter, and for the majority of women it's a really nice fit, so it stays in. It has the connector on the end, so you can't really sit with it in very well, so you have to go between kind of lying back with it in to be upright on a cushion, and then you can get into standing. It'd be great if we had something even softer that you could actually sit on an exercise ball and, you know, do some of your Pilates type exercises with a really soft electrode. There is a material out there that I have done some development work on, but it's not an electrode yet. But that would be the future for me.
That's exercises while standing up or walking is a bit new.
Okay.
It's
functional. It's how that muscle's meant to be. It's not meant to just be there when we're lying down.
Yeah. But actually, I remember from manual, it didn't, or maybe I figured it out myself. I don't know. I have the idea that you should only use them while laying down.
No, not the case. You can be active. I mean, some patients will choose to want to lie down because they need to concentrate on the STIM, so that's probably a development on. A lot of people will do it lying down, but ideally you don't want to be static. You should be as active as you can be.
Okay, that's interesting.
Thank you. Any more questions? Anyone? I don't think there are any more takers, if I can say so. Well, I just wanted to say, obviously, on behalf of TensCare, thank you very much, Julia, once again. It was really interesting and informative for all of us, even second time round.
Yes, some of you heard it twice now.
But every time you learn something new that you've missed last time. So thank you very much for that opportunity to collaborate with you. I hope we will be doing that more often, more regular in the future. And then
it'd be nice to be asked back. Yes.
Yeah, and if any of our guests have any questions later on, do not hesitate to email our account managers. They will get in touch with you as soon as they find information from Julia. Julia have extended, I think, your time to us in terms of questions if we have. That's what we've discussed.
Yeah, I'm happy to help if needed.
Get in touch, yes. And thank you very much for the time, and I'll see you on a different presentation. There's another one coming up straight after this one, Julia. So yeah, I might see some of the guests on another webinar. And thank you, Julia.
Okay. Well, have a good rest of the day if it's morning for you, or a good sleep if it's evening, depending on where you are in the world.
Thank you.
Bye.
Thank you.
Bye-bye. Bye.